I'm going to allow a little bit more time for attendees to join. We'll go ahead and get started. Closed captioning is available to attendees of this webinar. To turn on the captions, please see the CC Live transcription button in the toolbar at the bottom of the screen. My name is Kathryn Tucker. I'm a registered dietitian and contractor with Administration for Community Living. Welcome to our fourth event in our Food Insecurity Education Series. Today's event will focus on food insecurity referrals and interventions, and we have reviewed the importance of partnerships for combating food insecurity. State units on aging shared their promising practices on combating food insecurity during our second webinar. In webinar 3, we reviewed how to properly screen older adults for food insecurity. Once food insecurity is identified, what are we doing to ensure participants have the resources they need? Next slide. During this webinar, we will identify who can refer participants that are food insecure, understand how to develop warm handoffs to improve referral engagement, identify numerous intervention options available to those who are food insecure, provide potential referral options for networks to use when food insecurity is identified, and identify some training resources available to your providers. Next slide. I am so thrilled to have Jennifer Raymond from AgeSpan with us today as a co-presenter. Jennifer, please take a moment to introduce yourself.
Hi, good morning or good afternoon, everyone, depending on where you are. As Kathryn said, my name is Jennifer Raymond. I'm the Chief Strategy Officer at AgeSpan, which is an area agency on aging in Massachusetts, formerly known as Elder Services of the Merrimack Valley. And we have a wide variety of food access and food security programs. I'm excited to talk a little bit today about information and referral and warm handoffs. So thank you, Kathryn.
Next slide. So we'll go ahead and get started. Food insecurity occurs when nutritionally adequate and safe foods may not be available. It is the limited or uncertain availability of adequate and safe foods, or the limited or uncertain ability to acquire foods. We must always remember food insecurity is not always related to economics. Next slide. There are two types of food insecurity. The USDA uses the term low food security and very low food security. And those experiencing low food security have food, but it's nutritionally inadequate. This can lead to nutrient deficiencies and malnutrition. Those experiencing very low food security have reduced food availability that can lead to skipping meals or not eating. And this type of food insecurity is serious and will lead to detrimental health conditions. Next slide. In this webinar, we'll discuss screening. In the last webinar, we discussed screening for food insecurity, and screening tools can help you identify needs initially and when updating participant information. There are other ways food insecurity can be identified, and it may not always be through the initial call to the network. Within the Aging Network, we have numerous staff, volunteers, and participants who come in contact with other participants, and any one of them may be able to identify needs during initial intake or at any time there's contact. Encouraging communication within your organization can greatly improve interactions and the identification of need within your participants. Program intake, Aging Disability Resource Center staff, case managers, transportation staff, meal deliverers, congregate meal providers, volunteers, and in-home staff the services they provide may Identify a variety of factors that could indicate food insecurity in conversations during meals, calls, screens, and home visits, including limitation of ability to physically buy or prepare food, as well as limited financial means to purchase food. It could be the limited food in the home. This could happen when isolated or due to providing for grandchildren and other family members. Many older adults will also use their food to provide for pets. Limited physical mobility or weakness can be identified. Weight loss, loss of teeth or other dental issues, multiple chronic conditions and diseases. Overheard conversations or concerns about not having food or being hungry. Many seniors will look out for each other in congregate meal sites, senior centers, and senior housing. It's very important for staff to know their participants and have open communication. Telephone reassurance calls may identify issues by asking questions like, "What did you have for breakfast?" This allows a caller to identify not only whether or not they're skipping meals, but whether or not they're missing whole food groups. Additionally, volunteers and other seniors often get to know the participants as friends and may observe a need that staff isn't aware of. Next slide. Once we identify someone who is food insecure, it's important to get them connected to the right resources as soon as possible. Not only does this get them access to food and other resources sooner, it helps communicate that we care and we can be trusted. This can be done through a warm handoff, which is a handoff that is conducted in person whenever possible within your agency or between two agencies in front of the participant and family if present. Next slide. Everyone has experienced calling somewhere for help just to get transferred from person to person, having to repeat the same information over and over. How many times have you given up? A warm handoff alleviates these problems and encourages follow through by easing anxiety and showing we care. It engages the participant and family as part of the team. It ensures participants receive accurate information and prevents them from falling through the cracks. It helps to build relationships and communications within your organization and between partners. Warm handoffs also provide a safety check by ensuring proper information follows the participant through the process so that everyone is on the same page. Next slide. Given how valuable warm handoffs can be, it's important to ensure they're done properly. A warm handoff often needs to be done within your own agency first. So let's look at what a warm handoff would look like within a senior center. Mr. Jones comes in to see a senior center. I can identify that he needs a meal. So I walk him over to the kitchen staff to introduce him to the staff and help sign up for lunch. I introduce him to some of the seniors that come for lunch, and it helps to find someone who's a super volunteer who will look for someone with similar interests to introduce him to. I will then walk him to other staff members and introduce him to get him connected to other services either within or outside our agency. When looking at providing a warm handoff outside our agency, you can start by utilizing in-person meetings, virtual settings to connect the participant to the agency. Sitting in on the beginning of a conversation is crucial so participants doesn't have to continually repeat the same information. Agencies you've referred to can utilize warm handoffs to refer to the agencies to refer back to your agency for more needed services or to follow up after an intervention. You can use warm handoffs with healthcare providers, food pantries, SNAP, dietitians, and other community-based organizations. Training should be provided to staff who will be involved in the referral process. I've included a toolkit with resources, and that will be following at the end of this presentation. Next slide. So we're going to go through a couple of scenarios. So let's look together and discuss some scenarios related to food insecurity and connecting participants to resources. The first one is Mrs. Jones has been coming to the senior center to receive congregate meals. She tells the senior center staff when she comes in that her car is messing up and she's going to have to take it to get it looked at. She's going to be without a car for a couple of weeks, and she's afraid that she's worried she's not going to have enough food. She's not going to be able to come to the center, and she doesn't have enough food at home to eat regularly. The staff gives her a number for the Area Agency on Aging to sign up for transportation and a number for the food pantry. They're very kind, and they tell her to call those numbers. So next slide. Did they handle this situation correctly? There's going to be a poll pop up, and you can put in your answers. And then we'll kind of go over some scenarios. So when the poll pops up, just answer yes or no. Okay, I think we've hit a stopping point there. We can end the poll. And we can see the results. So next slide. So the answer is no. What should have been done, and there's several options. Staff could have called the AAA to discuss Mrs. Jones' situation while she was there with them. Then they could have worked on signing her up for transportation to the center to continue participating in the congruent meals. Alternatively, they could have switched her over to home delivered meals or other nutrition services like a food box. Next slide. Some other options, they could have also called the food pantry to introduce them to Mrs. Jones and explained her situation. Then they could have handed the phone to Mrs. Jones so she could speak directly with the food pantry to discuss next steps. They may have also been able to talk to Ms. Jones about SNAP benefits. Next slide. The next scenario, and this is a simple one, Mr. Smith comes into the congruent meal site to get a meal. Staff explains that he can be put on the wait list because he should have signed up the day before. Mr. Smith nods and leaves. So next slide. Did they handle this situation correctly? So the next poll will pop up. Okay, I think we're at a stopping point. Okay, next slide. And no, which most did agree with that. The staff could have helped Mr. Smith sign up for the next day's meal. By just having that conversation with him, getting him started, it alleviates the stress of maybe keeping him from coming back again, having to have that same interaction. Then they could have introduced Mr. Smith to the other participants and shown him around the facility. Additionally, they could have introduced Mr. Smith to other staff members and to make sure there wasn't other services that he needed to be connected with. They could have provided a warm handoff to a food pantry if needed and continue to be a resource. Following up to make sure he comes back the next day is important to ensure he is receiving the services that he's needing. And we would then recommend even following up in a couple of weeks for maybe other services that he may have gotten connected with. Next slide. So now I would like to turn it over to our guest speaker, Jennifer Raymond, to talk about referrals and interventions to help combat food insecurity.
Thank you, Kathryn. I really appreciated the scenarios that you shared, and I think all of us could look at those scenarios and tie it back to an actual real-world experience that we or some of our partners have had when it comes to addressing food-related needs, food access, food security, and nutrition-related needs. As Kathryn shared, both in her conversation and through those scenarios, the power of that warm handoff is really something that's incredibly invaluable, both in terms of building the relationships with the consumers that we hope to serve. It builds that trust, it builds that understanding that they're going to be able to come to us with a challenge. And if we're not able to address that challenge, we're able to make the right connections and do a warm handoff to address it. But it also is a tremendous asset for us in terms of building the relationships with other external stakeholders, like potentially healthcare partners, and you'll hear a little bit about that. It's really powerful for them to see that we have this wide network of partners and resources, and that we really have a strong knowledge base around nutrition related needs and resources, as well as other health related needs. So that is incredibly powerful. If we can go to the next slide, I just wanted to talk a little bit about some of the interventions and referrals that we want to be looking at when we're faced with a consumer who has some food security or food access needs. And the first of these are those that are really embedded within the Older Americans Act, and we can create great value for our consumer by aligning with those other services that are part of the Older Americans Act. Obviously, the senior nutrition program is at the very top of that list, whether that's home delivered meals, or many providers also dipping their feet into medically tailored meals or culturally appropriate meals that deliver to the home and don't get just dropped off. They have that set of eyes and ears that are able to look at the consumer and provide other safety around that, but also in terms of our congregate meal services. And I know many of you call these not just congregate meals, but community meals, those meals that come together not just with a purpose of addressing food access and security, but also have that added benefit of combating social isolation and loneliness and creating connection. And I know we're all excited to see many of those congregate or community meals coming forward. But it could also be other innovative nutrition services like food boxes, medically tailored food boxes, supplements, all of those other kinds of things involved that can be part of the Older Americans Act work. In addition to that, the in-home services that many of you provide, and that can include things like, having volunteers or staff or providers who are able to go in and help with grocery shopping, grocery delivery, meal preparation, those kinds of in-home services critical to the Older Americans Act. Telephone reassurance. I know many of you use your Title III dollars or some component of those Title III dollars to lift up programs like friendly visitor programs, whether that's in person or on the telephone, where you're able to just check in with someone, see if they've had new needs that have come up, make sure the meals they got met the current needs, and just have that conversation so that they, think of us when they think of the other kinds of social supports they might need as they continue to age. Transportation, another valuable Title III service that many folks can provide. It is amazing to me to hear the difference it makes for some people if we're able to provide them transportation to a large grocery store, as opposed to the choices that they have to make if they have to walk or get on a bus and can only carry 2 bags back, and they're really limited on the types of places that they can access food. And you've heard stories about people being able to take transportation to the mobile market, to the food pantry. So if you can embed and align your transportation work with your food access and nutrition work, that's another powerful piece. Case management, we could have a whole conversation around the interconnection between case managers, care navigators, those folks that are really looking holistically at a broader range of in-home services that a consumer needs, and how sometimes we can use nutrition as that gateway to open the door. Maybe they're not ready to have someone come into the home and provide more robust in-home services, but they're willing to start with getting some meals to help them manage their health. So that case management, care coordination piece is incredibly valuable, and that will come up again as we talk a little bit about referrals from external stakeholders and things that can be done outside of the older Americans out. Health screening, I think that goes without saying, so I certainly won't insult your intelligence by talking too much about that. Health promotion, disease prevention, the evidence-based programs, the Title 3D programs, whether it's, the chronic disease self-management program or a behavioral health program. We've all had those situations where we first connect with someone through a nutrition need, through a driver making the visit and dropping off the home delivered meals, and then walking away from that and feeling like, gosh, there's something else going on. I think this person would benefit talking to someone about a behavioral health issue, or better understanding how they can manage their diabetes. Those are folks that are wonderful cross referrals into the evidence-based programs. And then finally, the caregiver, the family caregiver support programs, whether it's grandparents caring for grandchildren or younger people in their lives, or whether it's spouses caring for one another as a result of some Alzheimer's related dementia challenge, being able to say, you know what, I know you've got it under control in really great ways. How about we look at providing meals on a daily basis? Is that something that can alleviate a small piece of the caregiver burden? So again, meals and food becoming a way that we begin these conversations. If we can go to the next slide. Many of you on the call today, as well as other food service providers through the Older Americans Act and otherwise, have now sort of started to dip your feet into how you can get and receive referrals from external sources. So I know a lot of you have become benefit enrollment centers, or participate with other benefit enrollment centers, whether it's at the food bank, the health center, or some other kind of community-based organization. Those SNAP benefits, those SNAP Ed benefits that they help people to secure, we know they don't cover all of the resources. So how can a SNAP or benefit enrollment center make a warm handoff or a referral to our nutrition program in a way that allows for us to provide meals while they're waiting for their SNAP benefits to come through, or vice versa? How can we identify folks who we think are eligible for SNAP, and maybe they don't understand how to do the application, maybe they don't feel like they're eligible, or maybe there's some kind of stigma? Those are really nice external referrals from us into those benefit enrollment centers or other SNAP benefit providers to sort of help those resources grow and help the dollars each month stretch so that folks can make some of the healthier decisions that they'd like to make with respect to food. The commodity, the food programs, the farmers market programs, I don't know about you all, but we always have more folks who are excited about those programs than we have capacity to serve, but making sure we're working with those partners who are lifting up farmers markets or other kinds of food pantries, grocery delivery programs, mobile markets, and making sure that we have a process, formal or informal, where we're able to share the right information about each other's program. And when we identify someone who needs a little bit more help, that we know, Kathryn is the person that I call and make that direct connection with the consumer too. So all of those programs, including some of the newer programs that are coming out, like food pharmacy programs that are similar to mobile markets or food pantries, but really look at sometimes the physical or behavioral health chronic conditions that an individual has, and sort of helps to tailor the foods that they get from a food pharmacy program with the needs that they have in managing their chronic health conditions. The next two things here are, really exciting external partners to be thinking about both today and as we move forward. And they really evolve around some policy potential changes, like Medicare waiver changes, as well as some increased contracting and partnership with healthcare providers and care transitions. Here at AgeSpan, we're very fortunate to be in a state like Massachusetts, although there are many, many other states that are doing the same kinds of things, where the state is moving forward these 1115 Medicaid waivers with CMS that allow us now here in Massachusetts to provide medically tailored meals, provide medically tailored food boxes, grocery gift cards, grocery shopping trips to do some education and some resources for folks who have traditionally not been eligible for those kinds of services. I know Oregon is another state that is doing a ton of that work, as well as California. So, encouraging those conversations between your state unit on aging and your state Medicaid office to talk about the role of nutrition in addressing health-related social needs, just first from a lens of helping the actual consumer, but also from a lens of creating enhanced quality and savings and sort of appropriate allocations of dollars related to needs for nutrition services. That same kind of policy change that we're starting to see, and the ability to create those external referrals, is happening with managed care organizations, healthcare providers, and other care transitions programs. So all of that work that you're doing now and have done for many years to create a reputation as an organization that can do warm handoffs with healthcare and other providers, that has an awareness of the very broad food access resources within your community, now is an opportunity to really talk with healthcare partners about how you might collectively create a stronger impact. And then, of course, the CSEP, or the Senior Community Service and Employment Programs, another really, really valuable way for us looking at additional sorts of referrals from and to external partners. Go to the next slide. The types of referrals, we've given 3 examples here, but the types of referrals that you might receive from an external partner really run the gamut. And, it's a place to create some creativity. We have had many community-based organizations, area agencies on aging, other nutrition providers who have had really good luck in developing these relationships, contractual and otherwise, with healthcare providers, so that the provider or the case manager who's talking specifically with the consumer every day can now identify somebody who might be appropriate for our nutrition programs, who might be eligible for our nutrition programs, and they can do those one-by-one referrals over. And we'll talk a little bit in a moment about some of the mechanisms to do those referrals. But I've seen them, range anywhere from telephone calls as the warm handoff to do the referral, to Excel spreadsheets that are followed by a phone call, to faxes, all the way up to really impressive technological databases and platforms that allow for it. But that sort of one-by-one referral of a consumer from a healthcare provider or a case manager into a nutrition program. In other areas, we're seeing that there are healthcare providers, for example, who understand the value of connecting people with food and nutrition resources as a way to improve physical and behavioral health. And they don't want to just refer them over one by one. They would like to develop a relationship where every month you're getting 25, 50, 100 or more referrals from them. And so these healthcare entities have the capacity to look at their patient databases, to look at their internal registries of people that they touch, and to think about, where they want to make the biggest difference. And it may be that they say, people over the age of 60 who have diabetes, type 2 diabetes that is not in good control, we're going to send over 20, 50, 100 of those referrals this month and give you the opportunity to put them through your screening process and see what they might be interested in. So that's a really exciting thing we're starting to see more of. And then, of course, that self-referral, it's always important to make sure that at the end of the day that these resources are accessible easily to the people who actually need them. So it doesn't always have to be a scenario where a consumer in the community has to go through their case manager or healthcare provider or someone else in order to access the program. So making sure you have some kind of process for self-referral so the consumer can connect you directly and sign up for meals or ask how to get into the diabetes self-management program, that kind of thing, or ask about transportation to the grocery store. Next slide. To talk a little bit about referral workflows. And, I will preface this by saying, if you've seen one workflow, you've seen one workflow. There are so many different creative ways for folks to do that. But it's incredibly important that if you're going to be accepting referrals from an external source like a healthcare organization, there's really a ton of work done to clarify the roles of each member of that outreach process. So if they identify someone who they screen and say, this person is food insecure, is that enough? Is that, are you going to be prepared to take a referral that says this person is food insecure? Now you go forward as the community-based organization or the nutrition provider and do the more in-depth screening and outreach and determine, what programs are they eligible for after conversation with the consumer? What do they want? What matters to them? Is that the kind of referral process that you're looking for from a healthcare provider? Or do you have expectations that the provider is going to be able to say, okay, we've screened this person, we know they're age eligible, we know they're geographically eligible, we know they need a Latino cardiac meal, or we know they need to be in the diabetes self-management program. So you're wanting the healthcare system or the external referral partner to do that kind of a lift and refer someone over to you for a specific program, for a specific meal, for a specific purpose. And there are benefits to both approaches and benefits for approaches all along the continuum. I think as more community-based organizations make these matches between their Older American Act services and other services, we're seeing value in saying to healthcare, just send us people that you think are food insecure, because we're going to spend half an hour with them and do a SDOH screening, and we're going to be able to see, yes, they definitely need food. They definitely need medically tailored meals. but we can also help them with this challenge they're having around transportation to non-emergency medical appointments. Or we can also help them in terms of challenges they're having around hoarding or home modifications or caregivers. So you really do have to think about what you want from an external relationship, but really importantly, think about how those roles are going to be clear from the beginning so that everybody's measuring success in the same way. If you want the health system to be responsible for scheduling workshops, contacting staff, doing the enrollments, collecting data, following up with participants, all of that needs to be, really spelled out in the beginning so that you're clear. And then, one of the things that I think we do a good job at and can always do better jobs at is making sure we have the right processes in place so that all of the work that we do with healthcare partners and others is HIPAA compliant and does honor that privacy and portability piece that we want to make sure that consumers have come to us to rely on. So developing the right HIPAA procedures, not just with respect to what it means, but how you're going to make sure that you're compliant. Is it different technology systems? Is it training of staff? Is it a combination of those things? So next slide. Technology-based referral systems. A moment ago, I talked about making sure you have some system or some capacity to make sure you're able to manage these referrals and that you're able to accept referrals in a warm handoff kind of way. Again, it can be in some cases as simple as folks using Excel spreadsheets that are protected with different providers or using phone calls. There is a rising industry around technology-based referral systems. And, I think for those of us that do social service work, community-based organizations work, we're the experts at connecting people to resources. We're the experts at being able to work with a participant and understand what matters to them and help them prioritize the actions and the resources they want to connect with in order to remain independent. We're learning how to do all of this in a world that has increased advanced technology. So there are some examples here of different tech-based resource systems that are out there. There are others that, the healthcare systems are looking at that make it easy for a healthcare system to make referrals out to a community-based organization and for the community-based organization to provide information back. And there has been, I'm going to paste it into the chat, and I'm not sure if you'll be able to see it or not, but we'll get it to you if not. There is a really nice function checklist that was developed in part by US Aging, and it does help community-based organizations think about the different factors they need to be considering when picking a technology-based referral system, if they want to go the technology-based referral system. So I know these slides and the recording will be available, and you can take a look at the sample of referral systems that are out there. We can go to the next slide. Data or data, however you pronounce it, sort of making sure at the end of the day, when we're accepting these referrals, whether they're internal or external referrals, we have a common understanding with our referral partner as to what data is important to track and how we're going to track and share that information. We know there's a bare minimum of data that we need to collect to meet our obligations under the Older Americans Act with respect to data. but it's important to think internally about something above the bare minimum, both in terms of how helpful that data will be to collect, as well as how onerous that data will be to collect. So tracking all of the efforts that you make to outreach to a consumer, to attempt to engage a consumer in nutrition or other services is really important, because it, lets you know what the lift is. I think sometimes people who don't work in this field think, oh, you get a referral for somebody that needs meals and you call them and they pick up the phone on the second ring, maybe the third ring, and you get them signed up for meals and they get the meals the next day. And we know through our data collection and through our conversation that there are many consumers that it's harder to reach. And so those efforts that you make, does it take 2 calls? Does it take 3 calls to pull someone in, is incredibly important, as well as the type of outreach that you do. Is the call enough? Is it more effective to have community outreach workers or community health workers who represent the communities that you serve make trips to the home and have conversation that way? So tracking outreach data, tracking those sort of common needs and common resources that you utilize are incredibly important. Looking at reasons why folks refuse service and tracking those common reasons for refusals of services or inability to connect people with resources, incredibly important. Attendance, participation in the nutrition workshops or the congregate or community meals. Completion rates. If you sign someone up for the diabetes self-management program as a way to help them make some behavior changes around nutrition services, but only 25% of the people that show up or sign up actually complete the program, it's important to have that information and look at why you're having those numbers. At the same reason, it would be important to understand when you have 100% completion rates, why is that important? And then, frankly, my favorite one, the one that gives us the best testimonials, the best kinds of stories, but it also is the hardest one to quantify, satisfaction surveys. When you serve a consumer for 3 months, 6 months, 9 months, a year, what do they think about the services? How can they help us hold the mirror up to what we're doing as well as what we're not doing, and use quality improvement cycles, PDSA and other cycles to help improve services and activities? And I know that those are the hardest ones, like I said, to kind of quantify, but those patient reported or consumer reported satisfaction surveys are important. And then outcomes. I think sometimes we think outcomes means that, did someone do better with their diabetes measures every month because now they're getting medically tailored or home delivered meals from us? That's certainly a phenomenal outcome, and working with healthcare partners can be really helpful. But also it's important patient-related outcomes. If a patient is able to report, I am now eating 5 servings of fruits and vegetables a day, twice as often as I was at the beginning of this intervention. That's a really powerful outcome that can come from the patient. But again, having some common understanding as to what the data that you want to track is going to be is incredibly important, so that you can make sure you're all measuring success equally. You can go to the next slide. We're getting there. So some of the things that you can do that enhance the ability for these cross referrals, both internally and externally, to be efficient and productive and beneficial. We've all talked about no wrong door many, many times. It's the same thing for the nutrition services. And, it always makes me cringe a little bit when we hear that someone came in the door through caregiver or came in the door through protective services. And instead of us saying like, oh, let me get the nutrition person on the phone with us right now and let me physically do this handoff, we say, okay, so you might be eligible for nutrition services. Here's the phone number to call. Here's the email to call. We, no matter what door internally or externally folks approach, we want to promote the idea that we will take responsibility to getting them connected to the right service without them potentially getting lost in the system. We talked about integrating technology and some of the technology partners that are out there to help us accept referrals, collect data related to referrals, analyze that data, and then make changes to our programs consistent to what the data shows us. I hope that this next part doesn't need to be said. I know all of us working in this field understand that it's incumbent on us to make sure that we're looking at the communities that we serve, not just the cities and towns, but the individual communities within those cities and towns, and addressing those needs that might be different in a way that honors culture and ethnicity and race and all kinds of other factors that make our communities diverse. Community health workers, community outreach workers are incredible ways to do that. If you're fortunate enough to have bilingual, bicultural staff, you're at a higher point, but also using that data that you've collected to say, gosh, we've got this diabetes meal. It's not culturally appropriate. It doesn't have the needs that our Latino population has. Can we pilot a culturally appropriate, a Latino diabetes meal, a Southeast Asian cardiac meal? So thinking about the right partners to help you pilot those kinds of things. And I'm more than happy to talk with folks about a successful pilot we had here in Massachusetts, where we started serving about 40 individuals with Latino diabetes meals. And today we serve over 200 individuals with those meals. Making sure that your INA and your ADRC services understand all of the work that's going on, that is integrated, that you're having conversations with those other providers on a regular basis, and that you're tracking common measures, common data, even something as basic and simple as demographic information like zip codes. I guess it's not demographic, but that kind of information. Understanding the role of your social workers, your registered dietitians, and increasing their understanding of the way that we work with the external partners. It's not, just because we want to put more work on people's plates. It's because the Older Americans Act dollars don't always meet all of the needs that we have. And by working with external partners, we have a potential way to grow the work, to grow the reach, and that those social service professionals play a really important role. And then making sure we don't stop at providing the meal or providing the food, but that we're looking at ways to provide nutrition education, whether it's through Title III-D or through another way. And, we have the capacity to look at, resources are tough, but if we have a registered dietitian or a nutritionist who's willing to work with one of our academic partners and use interns as different ways to provide permissible nutrition education within the scope of their work or their expertise, using friendly visitor programs or other kinds of programs to help deliver groceries, and then really making sure that all of the work that you are doing to advance food equity, to address food insecurity, is in line with what your partner organizations across the community are doing. So, how do you make sure you and the food bank are rowing in the right direction at the same time? When you hear people talking about initiatives like food is medicine, how is that going to impact your work? So being really involved in those kinds of community campaigns and community awareness is incredibly important. We can go to the next slide. I think this is the point that I get to pass it back to Kathryn. So Kathryn, it's all yours.
Thank you, Jennifer, and thank you so much for sharing such a wealth of information for us all. The ACL's Nutrition Aging Resource Center website has numerous resources for senior nutrition program providers, including tip sheets, guides, and more. I've included many of these resources at the end of the presentation, and the links will also be found on the website. Next slide. Free training is available at the following sites. The FRAC training is very helpful to identify and encourage SNAP applications among older adults. This training deals with a Hunger Vital screen, which is that 2-question food insecurity screen. FRAC's free online course is available to help healthcare providers address senior hunger. However, it is the whole program can very well be used for the community setting as well. So don't let the healthcare provider part scare you away. I have taken the training and it is a very good training. Next slide. The National Institute of Food and Agriculture has a nutrition security webinar series available, and it's on this website as well. So that's another series that you might find helpful for your organization. Next slide. So once food insecurity is identified, how are we ensuring our participants are receiving the services to improve their food resources? Simply identifying food insecurity is not enough. So once food insecurity is identified, our first step is to utilize a warm handoff when referring participants to any needed service within our organization or the Older Americans Act. Then identify potential interventions available within or outside your agency that best meets the participants' needs. And then provide a warm handoff, and that can be done internally and externally as well. It's difficult for many people to make that first step to call. And so us being able to provide that warm handoff makes them more comfortable. Follow participants through the process and follow up to determine whether outcomes are being met. And data collection can provide evidence that your efforts are working, and it can help identify areas for improvement within your system. Next slide. The recording from the past webinars and today's presentation will be available on the Nutrition Resource Center or the National Resource Center for Nutrition and Aging website. The link is at the bottom of the slide. During this series, we've highlighted collaboration, promising practices for the state units on aging, identifying food insecurity, and referrals and intervention. We hope to continue to develop more resources accompanying this series, including resources on data collection, which will be coming soon. Resources can be found using the link to the recordings, and a post-webinar will be sent out with a link to the recording and a takeaway sheet summarizing the presentation, as well as links to many of the resources. Next slide. We did not seek prior approval for this event for CPEU credits for dietitians. You can still receive credit under the CPE activity type 170 or 171 teleseminars webinars. Please visit the CDR website for further instruction. Okay, next slide. It is now time to go to the Q&A section. So if you want to enter your questions into the Q&A section at the bottom of your screen, you may, and after the presentation's over, if you have more questions, you can always email myself or Jennifer Raymond, and we'd be happy to answer those questions as well. So let's see with the questions.
So Kathryn, there were a few questions that came through in the Q&A that I've tried to answer. There was one question, and I don't know, I will open it to you or Kathryn or Judy or others that might have insight, and that was around progress for registered dietitians to have their services be reimbursable. And so I don't know if that's something you or others want to weigh in, or if that's something we can come back to after we've done some research.
I think, of course, dietitians can get reimbursed for diabetes and chronic kidney disease and renal medical nutrition therapy for renal disease. However, that was a big push with the White House Conference on Hunger and Nutrition and Health, is to increase those services within Medicare, Medicaid, as well as other marketplace providers. So that, I think that's coming. It hasn't happened yet, but I think that's definitely something that would be, we will start seeing a little bit more of.
I think another question that came through that I didn't type an answer to, because I think multi-layered, was around clarifying those kinds of food access, food nutrition activities that are funded under the Older Americans Act, and those things that are not. And again, if you or anyone at ACL has thought they want to jump in, I think that's a complicated one, because each state will have different ways that they define ways that you can cover, or dollars that you can use. And sometimes it may be that your primary source is Older Americans Act, and it's very specific what can and can't be used there. And other places there will be Medicare or Medicaid waivers, or mandatory contracting. So I know Massachusetts is very different. And I think, the best way to approach that is to really talk with the your contact or your representative at the State Unit on Aging, and get a more comprehensive answer to that. I apologize that I can't get more clear.
I am also going to include a link to the ACL website, which may include some more information on what services, but I definitely would recommend them contacting their local area agency on aging as well. Let me see. See if there's any other questions. Some other questions that I don't know if would be helpful is, Jennifer, have you seen any improved outcomes with your referral systems? Have you been able to identify those?
Yeah, I mean, I think that we have been able to see some pretty significant increases in folks saying yes to services, because of some of the warm handoffs that we've implemented, because of some of the, go into the field and visit people in the home. And I think primarily because we have, when we've accepted referrals, our first step in many cases is to do a broader SDOH screening and understand what other health related and social needs that someone might have. So maybe they're referred through the referral system over for meals, but in talking with them, there's a behavioral health challenge that they'd really like some support with. So we certainly have seen increases in folks being engaged in services. We've seen increases in folks, being able to share their own patient-related outcomes. So they, will self-report to us in surveys around better compliance with medication, better compliance with doctor's visits, that kind of thing. We haven't yet dived deeply, and I think it'll be some time before we can dive deeply into some of the clinical measures, clinical outcomes. Do people who have access to meals do better in their A1Cs every 3 or 6 months? That kind of thing we don't have yet.
And I think there was one question, is how have you handled programs or services for those who are disabled but not necessarily aging? And I know we're basically talking about the aging population, but I know with the senior nutrition program, if we have someone aging in a home and they have someone in their home who is disabled, they can also receive a meal through the program. But I didn't know if you all address those situations as well.
Yeah, that's a really good question. And this is where I think, coming back to that making sure you're part of the larger community conversation around nutrition. And so if I don't have the right funding streams to be able to provide nutrition resources to this person that has the disability, who else is out there that's able to provide it? And, I think one of the things that we saw tremendously during COVID and even now are a lot of different philanthropic organizations, a lot of different funders who are investing in food security. And so it's not unusual to see other community partners like the YMCA, like the food bank, like the grassroots organizations that are lifting up nutrition programs as well. So working with your community partners, having a robust understanding of the inventory of food access resources that are out there, and then creating those warm handoffs when it's not going to be a client that you can make a meaningful impact to.
Okay, I am not seeing any more questions, and it looks like we are at the end of our time. So I want to thank everybody for attending this webinar, and I want to thank Jennifer Raymond. Thank you so much for joining us and providing the information on referrals and intervention. We hope to send out the link to this recording of the webinar within the next 10 days. Enjoy the rest of your day, and thank you again for attending.